How you come?
Good morning, Keith. Can you hear me okay?
Yes, can hear you grand. And we have our members on and we have the first set of witnesses available. So
Okay.
whenever you're ready, we're good to go.
Okay. Yeah, go ahead then, Keith. Put us into
That's
public
us.
session.
That's us now, Chair.
Okay, good morning, members. I declare the meeting open to the public online. I'd like to welcome all of our members who are participating by video conferencing today. And can I remind members about the protocols regarding the use of electronic devices? So, members, no apologies have been received. Are members aware of any other apologies today? No, thank you. Okay, members, before I go into Chairperson's business, there is, I think, a strong possibility now, given latest developments, that there will be a plenary taking place at some point this morning. What I propose to do, members, is that if we can continue for as long as possible and take as much of the evidence as we can and suspend the meeting around that 12 o'clock or earlier, given members, however many members need or wish to travel for that. So I'll just be guided by the clerk as to, or by members as to when they're available. And I think if members are agreed, we continue taking the evidence sessions and try to work our way through them as much as we can and keep an eye on what's happening in relation to the plenary. Are members content with that? Yeah, okay. Thank you, members. Okay, members, a few items that I wanted to discuss this morning before we start. First of all, they are in terms of Chairman's business. The Curers motion, I want to thank all of the members for their contributions during that debate and to point out that we've received correspondence from Curers NI thanking the committee for bringing forward the motion. That's in your table pack at tab 10.19. As chair of the APG on Curers, I would also like to thank members for their contribution on that and to thank committee staff for putting the motion together and bringing it all forward to the committee. I think it was a very, very welcome, a very important debate in that sense. I do have to say there's a couple of things I was disappointed with, and I think Curers, and I can see that Curers are hugely disappointed. There was an indication during the debate from the Minister that he is not legally able to bring forward the COVID payment that he had said in January he was looking at. And I think that's a matter of huge concern and huge disappointment. But I wonder, would the committee agree that we write to the department requesting the work it is undertaking on providing what work it is now undertaken in providing that Carers recognition grant, what work has been done, and how he is working to ensure that grant can be made. Would members be content if we do that? The other element of it that I was concerned about was the issue about the Minister had indicated that he was going to carry out a review of the daycare and respite settings. To be honest, I would have expected that review was ongoing all the time and was underway, and there has been a lot of reviews clearly taken into a lot of other settings. It seems to me a bit unfair that the only setting that appears to be still the subject of restrictions that are preventing things from reopening at all in some cases is a matter of concern. And would the committee be content that we write and ask the Minister what's involved in this review, how long it will take, and to urge him to have that review completed as quickly as possible with a view to getting the services reinstated? Are members content with that? Yeah. Okay, members. The other thing I wanted to draw to your attention was an issue that has been raised with me in relation to universal credit for fees for dentistry and optometry. And there's a need for people to apply annually to this. This doesn't apply across the rest, any other part of England, Scotland or Wales. It came about as a result of changes in universal credit. However, there seems to be a loophole here where people have to apply, and I think they have to apply annually or maybe sometimes every time they present. Both of those sectors are concerned that some of the more vulnerable people who badly need that treatment, given the additional barrier, go away and don't come back or don't present back. And I have asked to meet with the Minister to discuss that, to see if there's a way to close that loophole and to ensure that vulnerable people are accessing those two important services on the same basis as everyone else. So just want to flag that to members. There may be more correspondence to come on that, which I'll share on it. The other thing, members, and the last thing in terms of Chairperson's business, I do think that in relation to the comments that have been widely discussed from the Europa Hotel, I do think as a committee that we should indicate our support to the Minister, and that we in no way support those comments, and that I think it will be appropriate that we write to the Minister in that respect. Would members be content? Yeah, members content. Okay, thank you, members. Going into draft minutes. Item 3 there, refer you to draft minutes of the 10th of June meeting, which is a tab 3.1. Are members content with the minutes? Yeah, thank you. And there are no matters arising from the minutes. So members, we're going to move then into our first briefing this morning, which is on the Severe Fetal Impairment Abortion Amendment Bill. And this morning we're receiving a briefing. The first briefing is from the Royal College of Obstetricians and Gynaecologists. And members, we will begin today's briefing with the first of 3 evidence sessions on this bill that's in front of us. Can I advise members that the representatives from the Royal College are here today to give evidence on the bill? I refer members to the written submission from the Royal College at tab 5.1 of your pack, and to the written submission from the Fetal Medicines Consultants Belfast, which is at tab 5.2. So I would now like to welcome by video link to our meeting Dr. Carolyn Bailie, and Dr. Carolyn Bailie is Chair of the NI Committee of the Royal College of Obstetricians and Gynaecologists. Can you hear us, Carolyn?
Yes, thank you, Chair.
Okay, you're very welcome. And Dr. Jonathan Manderson, and Dr. Manderson is Fetal Medicines Consultant in the Royal College of Obstetricians and Gynaecologists. Can you hear me okay, Dr. Manderson?
Yes, I can.
Okay, well, Tafal Birch, you're both very welcome to the Health Committee this morning. And I will now go back to you, Carolyn, to see if you would like to lead on a briefing for members, and then we can maybe get some questions and answers.
Thank you, Chair. Yes, I should just say that both John and myself work as fetal medicine consultants in Northern Ireland. So thank you for the invitation to speak to the Health Committee. Our understanding of this bill is that it will remove termination of pregnancy for severe fetal impairment at all gestations, whilst allowing termination of pregnancy to continue for fatal fetal abnormality. And I suppose the first thing I would say is that fatal fetal abnormality is not really a medical or clinical term. I think it is a term that was first used by the European Court of Human Rights. It can be very difficult for us to distinguish at times whether it is a fatal fetal condition or whether it's severe fetal impairment. And there's a lot of interplay between both of those terms. So, for example, in one pregnancy, a fetus may die inside the womb at 16 weeks gestation with a fetal condition, and in a different pregnancy, the same condition may allow a live birth, and that baby may survive for several weeks following delivery. So it's very difficult, and the use of these two terms doesn't really reflect the complexity of the cases that we look after. At one stage in 2014, we did meet with the Department of Justice, and at that stage they had raised the fact of fatal fetal abnormality, and could Northern Ireland, our COG, give them a list of fatal fetal conditions. And we highlighted to them at that point that there were real problems with using that term, and that it would be impossible to create a list, and that the term that we had used at that time was severe life-limiting conditions, really to encompass both of the terms being used today. So we have real concerns that if this bill is passed, firstly, that for some fatal fetal conditions, clinicians will no longer have the confidence in some of those conditions to provide care locally, for fear of ending up on the wrong side of the law or the regulations. And we know that colleagues in the Republic of Ireland have had such experiences. And secondly, we're really concerned that we will end up in a similar situation to what existed between 2013 and 2019, when clinicians were anxious and unclear about what was meant by the term an adverse effect on maternal mental health. And that was that arose really because of some of the language that was being used around termination at the time. There were differing legal interpretations of what was meant by mental health, and there was a real lack of clarity. And doctors were fearful of this, and therefore they no longer had the confidence to look after women locally. And so when women were being given the devastating news of a diagnosis in what was a much wanted and precious pregnancy, they felt they could no longer look after that woman in Northern Ireland due to the fact that she was distraught and that she felt she couldn't continue the pregnancy to term. So we feel that if the bill is passed, that many women will have to travel to Great Britain in these really difficult, distressing circumstances, that they won't be able to be close to family or to their local healthcare teams, that they will yet again have difficulty in getting post-mortem examinations, and that they will then have to suffer the harrowing experiences of bringing the remains home for burial or cremation. So I think it's also important to say that the number of terminations after 24 weeks for severe fetal impairment is really, really small. And many of these, or most of these, are actually just after 24 weeks. So it may be 24 plus 2 days or 3 days. And often the reason for that is because it can take up to 3, sometimes 4 weeks to get results of detailed genetic testing, such as microarray. There are some other fetal conditions where there will be a normal 20-week scan, and the problems in scan don't become apparent until several weeks after 24 weeks. These are not at all common and often are severe neurological conditions. And I think there are other conditions where there is a problem on the 20-week scan, but as the pregnancy advances, those structural abnormalities become much more pronounced and enlarged. And that might result in a really complex surgical delivery for the woman that will confer significant morbidity and which might affect her fertility and her chances of carrying a further pregnancy. So we have weekly multidisciplinary team meetings in the Fetal Medicine Centre in Belfast. We will convene a meeting more urgently than that if there is a time-limited case. And there are a wide range of different health professionals involved in these discussions. And certainly beyond 24 weeks, there would always be a discussion between 2 fetal medicine specialists, the consultant's own obstetrician, fetal medicine midwife, a specialist, which is often the geneticist, but could be a paediatric surgeon or a fetal neuroradiologist. The purpose of the multidisciplinary team meeting is to gather all the evidence, to discuss the diagnosis, the complexity of the diagnosis and the likely prognosis, and the options that would then be available to the woman and her partner, and to then relay that information to the woman and the partner to enable them to make the right decision for them. And it's important for these decisions not to be rushed. It's important that they have time to think through this really difficult and complex area. And since March, we are aware of some cases where decisions have been rushed because of concerns that parents have raised around the media attention that the bill has gained around the 24-week limit. A limited number of women will choose to have a termination of pregnancy when they're given the diagnosis of a fatal fetal or severe fetal impairment condition. And it's important that all women, whatever choices and decisions that they make, that they're well supported and receive good counselling and have good, adequate antenatal support, access to perinatal clinical psychology services. And for those women who do continue to term, that there is adequate support for services such as the Children's Hospice and other care providers. And we fully support that, parents should be supported in the longer term with adequate support, including financial support. Thank you, Chair.
Okay, thank you. And Jonathan, do you wish to make some opening remarks, or do you want to go to members now for questions?
Yeah, no, it's John actually. Sorry, but no, I would concur with what.
John, sorry.
You're okay. I would concur with what Carolyn has said. I mean, I work in the Ulster Hospital, Carolyn in the Royal, and I suppose between us we would see that our two units between us, which we're both fetal medicine consultants, would see the vast majority of fatal or severe life-limiting fetal conditions in Northern Ireland, and I suppose we're working really at the coalface with this, and we're obviously dealing with patients who have obviously very wanted pregnancies, happy to be pregnant, and they've come to often a 20-week scan or a scan at another period where they're really told some devastating news, and it's an incredibly emotive time for them, for their families. It's a major life event for them, and I think we see this day in, day out, and I suppose what we're really saying to the committee is that we're managing these patients. They are real live patients. They're from Northern Ireland. We're wanting to manage them locally with their local family support, and we're wanting to be able to deal with them compassionately. We're not wanting to be judging them. We're wanting to also manage them safely. We all have a high degree of training. We're lucky in Northern Ireland. We do have really highly trained individuals in this field. In the field of paediatric cardiology, neuroradiology, fetal medicine. I mean, we really do within Northern Ireland have a very highly trained group of people who, the majority of which have all trained elsewhere in the world as well. Myself in Canada, Carolyn in Texas, other people within centres all across the UK. So we're a highly trained bunch of people dealing with these conditions, and we're trying to manage patients and be supportive of them. And I suppose what we're really seeking is also the understanding of that and the support from the Health Committee in helping manage these patients locally. We don't want to get back into a position where these patients, the few of them that travel, will travel regardless of decisions in Northern Ireland. We don't want to get back into that position of patients having to travel to proceed with a termination in these awful situations for them. We want to support them locally, and we're also really concerned that we want to continue to be, that all our staff are very clear, and we are very clear at the minute of the rules and the guidelines and the law. For many years there were incredibly grey areas around that, and this goes back for decades really, and more recently as well, and we really do not want to go back. Carolyn and I are both old enough to have gone through that whole period, so we know what it is to be in that period for ourselves and for patients, and it's a really difficult place to be, when you've lack of clarity, both for us, especially the medical professionals, and patients. So we want to be supportive, and we want to make sure that we're doing the best for these patients, and we're giving them all the choices. As Carolyn said, we give them lots of information. We involve lots of groups that do care for children who have had severe disability or certain conditions. We have patient contacts, parent contacts, so we do have really good links now with the Children's Hospice, and I would also echo Carolyn's appeal, I suppose, for psychology support. We are incredibly lacking in this in Northern Ireland, and I would urge the Health Committee to look at this. We have a population of patients who come through with stillbirths, with fetal anomalies, who really difficult outcomes in pregnancy, and we do not have clinical psychologists in every trust across Northern Ireland to support these ladies. So there is a bit of a postcode lottery. There is one or two in the Belfast Trust, but really across some of the other trusts it's very piecemeal, and I think that is something that's severely lacking. And what I've found in my clinical practice, when you have all the correct supports and the correct information and the correct patient information leaflets for these patients, they make really well informed decisions. And a lot of these patients do continue with pregnancy, And I think the more knowledge you give patients, in some regards, the higher percentage of them actually will feel supported enough to continue with their pregnancies in these really difficult circumstances. So I think it is incumbent on all of us, doctors, but also on those making the laws and the rules and advising, also to be really cognizant and recognise that actually we can improve this further. And I suppose that's really what I would say at this stage. So, I'm happy with Carolyn to take questions. And I suppose what we're really trying to do is just give you a really clear picture of what it's like in these clinical circumstances and these really wanted pregnancies with patients, real life patients who are in huge distress. And it's a really these are difficult situations to manage.
Yeah. Okay. Thank you, John. And if I could just advise, when we go into the question and answer session, if everyone can make sure they're on mute when they're not speaking, and if everyone can use a headset, that does help with the sound. There has been little bits of breaks up in both of your sound, Carolyn and John. So if you have headsets, maybe give those a try. But we were able to follow you. Okay. So I suppose the first question I would have then, Carolyn, is for yourself. And you had said in your presentation that you had a concern that if the bill passes, clinicians would no longer have confidence to deal with some of these cases locally. So can you elaborate for me a little bit as to what you mean by that and what the impact of that would be?
Yes. Well, I suppose if we look at fetal abnormality, first of all, and I had mentioned that it can be difficult to distinguish between fatal and severe fetal impairment, and that there is a lot of interplay between the two. So it may be that for some conditions, and we're all aware of the intimidating language that has been used around termination of pregnancy and in 2013, doctors being fearful of being on the wrong side of the law. And I think that is still, something that everybody remembers. And we know that our colleagues in the South have experienced it. So I think for some of the fatal conditions, clinicians will begin to think, right, somebody might interpret this differently. Somebody might interpret this as a severe fetal impairment, but yet I know that in a lot of conditions, the baby will die inside the womb. I'm worried about being on the wrong side of the law, and therefore they act differently as people did after 2013. And similarly, prior to 2013, many of these women were looked after in Northern Ireland, usually under the clause where it said there was an adverse effect on the severe adverse effect on the mother's mental health. And it was acknowledged that a woman may have had underlying mental health issues, or that in those circumstances where a woman was given devastating news, that she was so distraught that she felt that she couldn't continue the pregnancy to term. And so some terminations of pregnancy were therefore undertaken on that basis. If we remove the severe fetal impairment bill, it means that there is nothing written down to make clinicians feel that they can clearly act and continue with the termination of pregnancy for a woman in those very difficult circumstances under the mental health regulation, which is currently Regulation 4 in the new regulations. And that goes back to the lack of clarity, the differing legal interpretations that we were given at the time when we asked what was meant by maternal mental health. And the impact of that would then be that those cases of severe fetal impairment, some of which may be considered fatal, that those women will then have to travel yet again to Great Britain, as they did between 2013 and 2019.
Okay, thank you, Carolyn. Your sound was poor there at a couple of occasions, Carolyn, but I was able to follow the most of that, I have to say. So, can I just check, Clark, is Carolyn's sound poor with you as well, or is it just...
Sounds okay at this end, Chair.
Okay, well, listen, so I was able to follow it okay, Carolyn, so thank you. Were you finished there on that answer?
Yes, apologies about the sound. Yes, I'm finished.
Thank you. Okay, the other thing then I wanted to just follow up with yourself, John, is around that whole issue of psychological supports and the fact that there's gaps within that, and I think hospice support was mentioned there as well. Can you sort of elaborate a little bit in terms of the difficulties that causes in terms of supporting people to continue with pregnancies?
Yeah, I think historically we've been really poor at this in Northern Ireland, and obviously we as doctors have been asking sort of, I suppose, for funding, yet another thing to be funded, but we see the need for it within pregnancy situation, because there, people having even miscarriages, moving right through to severe fetal anomalies, and then moving through to stillbirths, and then moving through to really difficult birth experiences, where they have very traumatic birth experiences. There's a huge number of people that are affected in pregnancy in a negative way, emotionally, psychologically. And certainly, our focus today on the severe fetal anomaly, fetal group. I mean, these women, these are wanted pregnancies. They come through, and we as doctors, because we're working every day, we have to remember that for this patient, this could be their one pregnancy or one of their most major life events in their life, and it's an incredibly emotive time, and I think they need supported. And we try our best. We see them, we counsel them, we're very sympathetic. We have fetal medicine midwives who would ring these patients and keep in touch with them. Some trusts would have bereavement support, but again, it's very piecemeal, and again, a lot of patients are not seen or don't have those facilities to be seen, and will go, will maybe have a review with a consultant in 6 or 8 weeks, but really what they need is ongoing psychological support from a professional trained in the field, and that will make their life moving forward better. Will reduce the numbers that then have like a post-traumatic stress problem, and will help them in any future pregnancy, because they enter future pregnancies incredibly nervous and worried. And I think as well that sort of those supports, adding those supports in at an early point for patients, will allow them to have the confidence to make good decisions, informed decisions where they're supported. So I think there is a huge need and a huge gap in our service here for in these sort of supports. I think Carolyn can maybe update. The Royal would have someone, but again, these people are inundated and really only work so many hours a week and just cannot see the number of patients coming through. And I see it within our service. Again, we really struggle to give these ladies the psychological support they need, and even when they're referred back to their GP to be referred on to a psychologist, the waiting lists are absolutely enormous. And just the earlier you manage these patients, the better. Leaving something half a year, 2 or 3 years down the line just does not work for these patients. So I think that does need looked at, and I would sort of encourage you all really to look at funding for that.
Yeah, thank you, Joe. And I have to say, actually, I have dealt with on several occasions, and I'm sure all reps have, not only and obviously the women who are impacted are first and foremost in their minds, but actually the impact on fathers as well in terms of stillbirth and loss of pregnancies is massive. But we're not even at that stage of supporting the women, never mind the other people and the other family members affected. So I think that's a huge issue indeed, and thank you for that answer. I'm going to go to members now. So first, I'm going to Paula Bradshaw, then Carol Killen, Jonathan Buckley, and then Jerry Carroll. That's who I have at this point in time. So I'll go to yourself, Paula, please go ahead.
Thank you very much for your written and oral presentations this morning. I asked a question last week, and I think it's probably more directed at you, John, and that's really just to give an outline of how long and what steps you have to go through in terms of training and duration and different posts does it take for you to become a fetal medicines consultant? Thank you. Oh, I can't hear, John.
I think you may be on mute, John.
I was on mute.
John,
Apologies.
you're on mute. Maybe we need broadcasting to. Yeah, go ahead now, John, please.
Yeah, sorry about that. I suppose to give you an example, we all train as general obs and gynae consultants, and that training takes probably about 9 years. On top of that, then we do, to become a subspecialist in fetal medicine, you do a 3-year training program. 1 year is research, 2 years subspecialty work within fetal medicine. Often that research extends out. So in my case, and I did a doctorate as well. So within that, so I was sort of training in that whole area for 4 years. One of those years I was in Canada, in Toronto, in a fetal medicine centre. So the majority of us have trained to that level. So we have all the general training that any obs and gynae consultant has, but in addition to that, we have an additional 2 to 4 years training. And then we're working, obviously, in those fields. The fetal medicine field within the UK is really a world leader, but it's also a very close-knit community. We would attend all those sort of yearly meetings with very close contacts with our colleagues across the UK and Ireland. We're really connected through the Royal College in London, and we would have trainees who train in Dublin and train in London and train elsewhere in our units and train across and go to some units specifically for training in certain areas. We have very strong links at the minute in Belfast with St George's Hospital in London, at a personal level and indeed at a work level. And we have a lot of patients, certainly in my unit, I would send my ladies with twin transfusion problems, laser treatment. Some of you may have seen Dr. Baskey on the television recently and saving babies' lives with doing fetoscopic surgery. That's the consultant that we link with in London. So we are highly trained. As part of our training, we train not just in fetal maternal medicine. We spend time in the pathology labs, in the genetic labs. We spend time in intensive care managing really sick patients. So it's a really thorough training program. I spent time with sitting weekly with a psychologist for about 3 months in clinics where she was talking to patients. So we have a really broad spectrum of training, and then obviously our practice is very clinical. So we're really dealing with patients, and we link with our practice with other specialties such as neuroradiology, looking at MRIs now. So technology keeps advancing. Genetics has advanced. So what we can do now and what we can do in the future will continue to advance. So there are conditions that can be tested for, within families now and you can predict risk. You can offer early diagnosis. You can offer, in fact, diagnosis before through IVF procedures before implantation. So there's a huge variety of treatment options for patients with really serious conditions that run through families. So we're quite a tight-knit bunch, I suppose, within the UK, and we are really, I suppose, we work in a multidisciplinary team. So we're regularly working with our paediatric cardiology colleagues, with our neuroradiology colleagues in the Royal, with our paediatric colleagues massively, working with them in counselling and management. And these patients would all be offered counselling with a paediatrician. They'd all be offered counselling with an expert in the area that the baby is affected in, such as a spina bifida case. We now have introduced a system where potentially those babies can even be operated on in the womb and referred over to either London or into Belgium. So there are huge advances, and it is a really highly trained area. So that's basically what all of us who are consultants in fetal, and I think really at the minute there's about 5 of us in Northern Ireland trained to this level. Hopefully some more coming on board within the next couple of years. But that's, I suppose, so we are the people, I suppose, often at the cold face who are, but that gives you an idea of really the training that we go through get to this point.
Thank you very much. It's very comprehensive. So I just want to know what your reaction then is that some of the accusations when we first debated this bill in the chamber, and that was that people like yourselves were coercing women into abortion, and that you were performing abortions on the ground of cleft lip and clubbed foot, as we've seen in headlines in the papers. What is your response to those accusations? Thank you.
Well, I can respond. I know Carolyn would probably be keen to respond as well. I mean, that's completely untrue. Very far from the truth. I mean, no baby would be have a termination for a cleft lip or a talipes or an isolated single defect like that. I think that the problem is that maybe there has been a misinterpretation of figures, and people do not realize when you maybe have babies with severe fetal abnormality, they have a mixture of a complexity of conditions, possibly involving their brains, their hearts, and on top of that, they may, in addition, have a cleft lip or a talipes of their foot. And that, I suppose, in those cases, those babies will have multiple abnormalities. One of them may be a cleft lip, but we would certainly refute that. We are a caring and compassionate group of people. We are trained at a high level. We're trying to manage really difficult situations, and we're managing our local population to a high degree. We do have, and we would encourage people to get postmortems. So there is an audit process really looking at what we have diagnosed in ultrasound, and then confirming that then by a postmortem of a baby, and that gives valuable information moving forward to future pregnancies. So we really strongly encourage that for women as well to go forward and have postmortems. So there is oversight to the system, and certainly we would refute a lot of those allegations that were made. It's really disingenuous, actually, to be honest. But maybe Carolyn would like to have a word on that as well, because it was quite something to hear all that.
Yes, thank you. I would agree with everything that John has said. And I know we practice in Northern Ireland, but even thinking and knowing the units that we liaise with in England, so, St George's, Birmingham Women's, Glasgow, that just would not happen in those units. And we just know that wouldn't happen in those units. And I think it emphasises the importance of having, good, strong, multidisciplinary teams to discuss cases, which ensures sort of good governance within units. I think that's really important. And of course, there is bad practice everywhere. I would think, I agree with John about, the isolated club foot or talipes and cleft lip. I imagine that is just listed as part of a spectrum of abnormalities in one baby, perhaps with severe chromosomal problems. But also the implication that these babies would be terminated up until term is just something which will not happen in Northern Ireland. And I know it doesn't happen in St George's. I know, obviously we have had discussions over the years, or things have arisen. So we're very well aware of what is acceptable and unacceptable in units in the UK. And I imagine that you always will get somebody who doesn't practice well. That is inevitable in any walk of life. And the protection against that is having strong multidisciplinary teams, good care pathways, and good governance.
Thank you both. Thank you.
Thank you. Yeah, thank you. And I suppose it does actually just brings to mind the fact that actually here in the north, families who have a bereavement of this nature actually also need to travel to England for paediatric pathology. given we don't have a service here on the island, and I have raised that with the Minister, but that's another significant gap and a significant hardship for families who have been bereaved. Okay, going then to Carol Nichillen. Carol Lanneray Lidahull.
Gormiagad Caherley, thank you very much, Colm. And Carolyn and John, I just want to put it in a record that I really appreciate not only you coming to the committee today, but certainly appreciate the professionalism and compassion in which you have to deal with every day, and particularly supporting women and families through some very, very difficult situations. So I want to put that in a record. I also want to put in a record that I trust your decision. I think we need to trust our clinicians to help people make the right decision for them. And I trust whatever decision people make as well. Mm-hmm. I think the idea and the question I would have is that in relation to this proposed bill coming forward, people who find themselves, and as you said, it's a very small percentage, but women will find themselves perhaps when they discover very late in their pregnancy that their baby is not going to survive and they want to make a decision to terminate. So, and that is the case where babies can't survive out of the womb. They will still have to travel if this bill or any other bill goes through. And then the issue that I have is that you raised it, John, and Colm raised it as well, that our psychological services aren't what they should be to support not only the women, but their families. So you've kind of covered that, and that's something Orlia in particular has really majored on. But one of the things, and Paula touched on this, one of the things I found quite disturbing, and even from talking to some constituents, that there is a suggestion in this bill that anyone who discovers that their child in the womb has either a cleft palate or a club foot will be encouraged to terminate. Now, that for me not only has hurt those families, but it's also hurt some clinicians as well. We received presentations from the Royal College of Midwives and NIACT last week, very, very credible and compelling and compassionate people like yourselves. So it's really just for your commentary on that, and just what you feel the implications would be in terms of your ability to practice and advise if this bill was to go through. Thank you.
Well, I think it is unfortunate that is out there now, that people do think that an isolated club foot or cleft lip may be terminated. I mean, that is just completely untrue. And if you speak to any fetal medicine unit in the UK, I would think they would also say that is completely untrue. And again, I think that is data that is recorded, but it is recorded as part of a spectrum of abnormalities in one baby, which usually reflects an underlying severe chromosomal or genetic condition. But the abnormalities are counted differently and separately. So I think it is important, it is important to try and dispel that myth throughout Northern Ireland. I think that's part of the problem with abortion, because it is such an emotive subject, and particularly here in Northern Ireland, that there are all of these ongoing discussions in separate silos, and there's a lot of secrecy. And I think we are all about transparency and the importance of, having good governance within trusts, which you can provide with good, very multidisciplinary team meetings, with very good care pathways, with very good support networks for parents, irrespective of what decision that they make, and possibly, more discussion about this regionally will help to dispel those myths and actually show what the support and what the pathways are for women who end up visiting fetal medicine, having to visit fetal medicine centres.
Thank you. Okay, thank you, Carol. And going then to Jonathan. Go ahead, Jonathan, please.
Thank you, Chair. Can you hear me? Yes.
Yeah, I'm hearing you, Jonathan. Yeah, go ahead.
Thank you, Carolyn and John, for coming to the committee this morning. Could I ask, how do you respond to the recent Scottish Cardress report on congenital anomalies, which said termination of pregnancy for fetal anomaly accounted for almost all of the non-live born babies, showing the impact of antenatal screening on the outcome of babies with these specific types of anomalies, and the fact that in England in 2018, 85.2% of pregnancies with an antenatal diagnosis of Down syndrome led to abortion?
Well, I think in relation to the figures for the last part of your comment about Down syndrome, I think firstly, a lot of women choose not to have screening. Screening is optional, and I think about 45% of women chose not to have screening. So I suppose the figures relate to those women who did have screening and where a diagnosis was made. I think there has been a lot of work done in the last few years in England. There was a consensus statement released by the college, or COG, and the Royal College of supported by the Royal College of Midwives and Society of Radiographers, which looked at sort of the terminology around screening and emphasising the importance of, proper education and the importance of proper counselling before a woman actually has screening and what the implications of that screening process are. So proper counselling both before and after, the importance of health professionals giving sort of non-biased information and not judgmental information. And I think the importance of women being aware of the support services that are available for children that do have disabilities. I think in Northern Ireland, actually, although there is much to be improved upon, that we have good networks and mechanisms in place, which of course can be improved. And that is something that can perhaps be discussed in future discussions with the Health Committee. I think there is a lot of education that needs to happen around screening. I know the RCOG had worked with Down Syndrome Association and some other groups, and they looked at the terminology that has been used in some of the guidance and the online e-learning platforms. And together they have modified that terminology. So I think, changes have been happening in recent years, and I'm sure there is room for improvement moving forward.
See, I suppose from what I've listened to there, and obviously your presentation was cutting out slightly with me. I'm not sure if that's on my end or yours, Caroline, but I feel that the approach is very much based on the perspective of mothers who want to end their pregnancies as opposed to the options. What would you say to someone with Down syndrome or another non-fatal disability who says that having a law that says unborn babies with disabilities like theirs can be aborted up to birth precisely because of their disability makes them feel like they should not exist?
Yeah, I completely can see why they feel like that. I think it is also, it is not, to my knowledge, something that happens in units in England. I can understand that there have been maybe one or two cases, but in good, well-renowned units, they would not consider termination up until term for a Down syndrome. And I know that from chatting to colleagues in England. So, and that would certainly not be the case in Northern Ireland. We would all be aghast at something like that happening. So I think, part of the problem in Northern Ireland is that the law has been very unclear And we did have a law that was based on maternal mental health in the past, which then became very unclear and women were having to travel. So I think each case is a separate case. Each woman is a woman with very different circumstances, maybe circumstances at home, maybe other health problems, maybe circumstances that really none of us really know until we're in those circumstances how we would feel and what support we feel that we have. So I know that the law is now based on a fetal problem, but all these decisions are made basically from the maternal perspective. And women make very different decisions, very many different decisions. So I would see that it is still coming from the maternal perspective, and that those decisions are made on a case-by-case basis after thorough consultation and counselling and giving information to the parents to make them aware of what support would be available, which may help them to continue with their pregnancy.
Yeah. Again, I would, I suppose, concur with what Carolyn has said. I mean, Northern Ireland is slightly different from England. We don't have the same screening that England would have. I mean, England would be screening for, and the reason Down syndrome is used is because it's the most common chromosome disorder. And I suppose in England, all units are offering screening in the first trimester, so in the first 12 to 14 weeks for that condition. Northern Ireland, we aren't. And indeed, if you were going to introduce a new screening programme for that, it would require money and training and all that goes with that. So we currently don't offer that. So it's done sort of piecemeal on patients that ask. And it's often done at sort of 15, 16 weeks as a blood test, but we don't per se have a screening programme across Northern Ireland to pick up Down syndrome. So what is happening in these wanted pregnancies is that things are being found on ultrasound at 20-week scans, or indeed patients are going privately and having private genetic screening at an earlier point and coming with a diagnosis of certain conditions. So it's not in any way a targeted search for program. I mean, the reason the 20-week scan is done is to pick up conditions that, so we can manage patients properly, have them referred to the right units, so the babies with cardiac conditions, gut conditions, brain conditions can be managed in the womb if possible, delivered and supported and delivered in the right places to manage them immediately after birth. And again, through fetal medicine, we're very much managing patients on a patient-by-patient basis, and we're respecting the decisions that patients are making, but we are totally supportive of whatever, and we would like to be supportive of whatever decision that particular patient makes within their, within what they have, the information that they have been given within their particular. And not every pregnancy is the same. And I suppose that is what we would say. We're very much supporting people and supporting them to continue pregnancies as well, and giving options in life-limiting conditions, where babies may not be expected to survive for very long, of linking through to the children's hospice as well is really invaluable. I've certainly had a number of patients who've even spent 2 to 3 weeks within the children's hospice, with their little babies, and I've found that really invaluable, making memories, and we're very much involved with that, and I suppose we would be saying, help us more in this regard, because I do believe that the more support we give these women, and I think it's really important to have that support and management locally, the more support we give them, the more women will feel confident to continue with pregnancy. But there still will be patients who make a really difficult decision in their lives that they don't want to continue with the pregnancy. And I suppose that in all situations, including Down syndrome, and those are really difficult places for those patients to be. And I think we do need to be able to support patients, whatever their decision is, because this hits everybody across all social divides, all religious divides, etc. And it's something in their lives that they need support with. And we would like, as local clinicians, to be able to do that.
Okay, well, I suppose probably, and going back to Caroline's point about it,
very brief, Jonathan.
The law sends a signal and says,
Jonathan, very brief question, please.
You can abort up to birth for Downs. So do you not think that it is odd that doctors are asked to fight to keep premature babies alive, while at the same time intervening to end lives of babies of exactly the same gestation because they have a disability? How do you think the double standard makes people with disabilities feel? Because I think this gets to the very nub of what the bill's purpose is.
Well, I don't think that the law does say that you can abort a baby with Down syndrome up until term. I think what happens is that for any conditions beyond 24 weeks, there is a multidisciplinary team meeting in fetal medicine units where all the information is available, including the diagnosis, the complexity of the diagnosis and the likely prognosis. And I would, from chatting to colleagues, suggest that in most units after 24 weeks, that in most cases of isolated Downs, where there aren't any other complex associated abnormalities, that most units would not agree to that. So I don't think that the law does say that you can abort a pregnancy with Downs up until term. I think that is,
that is not what is being practiced, and I think that needs to be very clear. We're not doing, that has been used a little bit. That is not what is happening, and that is not what we would be wanting to do. And I would agree entirely with Carolyn. Each case is taken as an individual case, but we would certainly not be promoting that in any shape, form.
Okay, thank you. Thank you, Jonathan. Thank you. And moving on to Jerry. Carol, go ahead, Jerry, please.
Thanks, Chair. Thanks, Carolyn and John, for your presentation this morning and the briefing paper that we got before. Just a couple of quick questions. I mean, I suppose there's some, information in your in the written evidence, which is quite important and useful. I just want to tease some of that out here this morning. I think the comment about needing to have, and if the bill is progressed, and that it will ultimately prevent, and I'm quoting here, a patient-centred, individualised approach to care for women who may already be distressed and ignore the clinical complexity of severe fetal impairment. I mean, we in the Health Committee constantly talk about having a patient-centred approach of care, patient-centred focus of health, and that's true for everything, and it should be the same when it comes to pregnancy in terms of terminations, and obviously I think it's important to challenge that idea that women are just deciding willy-nilly without consulting with their NDTs or their or whomever that they need or have to get a termination. So I think challenging that is important. Just the one of the paragraphs in your presentation discussed about terminations in England and Wales in 2019, where Down syndrome was mentioned. It says here there was a total of 12 abortions. So I'm not sure if that's just solely for a diagnosis of Down syndrome, but could you maybe tease that out? Because I think there's certainly what appears to be either a misconception or an inaccuracy in claiming that the majority of diagnosis of Down syndrome end up in a termination, which my understanding is that's not the case. And could you maybe either speak to that figure or maybe kind of challenge that misconception that is unfortunately repeated?
Yes, I thank you, Jerry. I think that those figures relate to after 24 weeks gestation, where it is most likely because there has been a late diagnosis because of some other complex problem in a baby with Down syndrome. So they can have complex cardiac abnormalities, sometimes quite severe structural neurological problems. And I think that is what that refers to. So later detection after 24 weeks. I think a lot of the discussion, about late termination up until term, I mean, that is just not accurate. Sometimes people will also refer to late termination as anything after 24 weeks. So there is a little bit of confusion as to, is it 24 plus 1, 24 plus 2 weeks, or are we talking about term? But the figures relate to Down syndrome after 24 weeks, where there was another complex abnormality detected, and sometimes those aren't detected until after 24 weeks.
Mm-hmm. Yeah, thanks. And just another quick point. In the presentation as well, it says about, and I think this is crucial. It kind of speaks to something what Jonathan said. The presentation said that some women will choose, in the event of a fetal diagnosis, some women will choose to continue the pregnancy with the option of palliative care, and we kind of touched upon that already. And that decision must be respected, supported, and again, an individualised care plan agreed. I think that's crucial here. This is really, from my and I think most of the committee's point of view, that you need to have a situation where people aren't forced to make decisions. And I think this bill actually, and we kind of teased this out a bit last week, might actually force women to make decisions before the 24-week period. And obviously, women should have access to all the palliative care and support and psychologist support as well. And just finally, the figure for, I think this is so if the law was changed, if the bill was passed, I think this would prevent 5 women a year from accessing the termination after 24 plus weeks. And to me, obviously, that's not only a tiny amount of people, but also the amount of distress that would cause those women seems to be quite large. And also, a lot of stress it would cause people who have, maybe had stillbirth or other kind of traumatic or difficult pregnancy. So I take it it's, you want to come in there? Sorry, Carolyn, yeah.
Yes, I suppose just in relation to the last 2 comments that you made, I had mentioned 5 patients in the report, but in fact there were less than that. And most of those were just after 24 weeks. So in the 24th to the 25th week of pregnancy. Most of those were because results hadn't come through in time. And obviously with data protection and privacy laws, we can't expose, to say what those conditions were. But they were very complex conditions. Unfortunately, we can't discuss them because we could then demonstrate the complexity of the nature of those problems. I think, and also in relation to your comment before that about supporting women who continue with the pregnancy, that is very much, I think, where, how we start off conversations in the fetal medicine unit. In the fetal medicine unit in Belfast, we do have relatively good support, but it could be better, but we have good antenatal bereavement, midwife support, clinical psychology. Most of the fetal medicine consultants have been to the children's hospice to see the hospice and the care that they provide. We have had meetings, including regional meetings with the children's hospice, and we're just about to start to pilot some care pathways with them for antenatal care and care during labour and after delivery. Just to ensure that the care is as comprehensive and as supportive as possible. We also do have a linked nurse midwife who works between us and the children's hospice, and she has come to the fetal medicine unit, fetal medicine clinics. She has come to some of our monthly large meetings with all the other specialists that call perinatal surgical meetings, which are very multidisciplinary. We have neonatal input into our medicine clinics several times a week, where neonatologists will come down and talk to parents about the implications of the problem and what it is likely to be like for the baby following delivery, and what sort of things that parents will have to expect. So there was a huge amount of support. I'm sorry if that didn't come across in my first presentation. That is very much what we are about in fetal medicine.
Yeah, thank you. Thanks for that information.
Okay. Yeah, thank you. Thank you, Jerry. And then I have Orlea and then Cara. So go ahead, Orlea, please.
Thank you, Chair. And just first of all to John and Carolyn, I would like to say just to express my thanks to you both in your role as doctors, as clinicians, who are obviously dealing with the most complex and difficult of situations, but who are clearly providing that support and treatment for many women and families going through something that doesn't bear thinking about unless you've experienced it yourself. I just want to say thanks to you both for that and for your comments that you have made today. John, on the issues that you had raised around the lack of clinical psychologists, so that's not a new issue that's came to the committee, and certainly not a new issue that's came through to myself. So we are aware of it, and we have actually been dealing with trying to open up a conversation with the Minister of Health to appoint a lead psychologist onto the management board for the department. So you're continuously getting that sort of input of, the level of need or the gaps that are there, just to make sure that those gaps aren't widening. But we are aware that it is a problem, and I'm certainly happy to continue on lobbying with the Minister and the department to try and sort of enhance those services, because I suppose the whole conversation that we're having today, it's been brought up repeatedly around the impact that all of this, that these situations have on, not just the woman's mental health, but also the mental health of the broader family that's going through it. And I think that, we've obviously seen in recent times, in recent months and over the past year, we have seen a good bit of progress around the perinatal mental health overall, and, some additional investment going into that. But I think it would be unfortunate if we were, almost taking a backward step, where although we are talking in very, very small numbers, Carolyn, as you had just outlined, of the number of people that this bill would impact on, the fact is that the mental health impact will be even more profound, even though it is such a small number of people. So it's just to say that. And but I'm glad, John, I wrote down all that feedback that you gave just around the gaps in the service. And as I says, I'm more than happy to follow up on some of that, and I will intend on doing that. So just maybe 2 points, if you could come back just with some views. I know that Carl had mentioned about the briefings that we had last week from RCM and NIACT. And I think it was in the NIACT briefing, they were obviously talking about some of the feedback that they were getting back from clinicians and doctors. And it was really a case of some of the arguments that have been made in the second reading of the bill just weren't based on reality. And that doctors had almost found this insulting, and they were fearful of that whole, that really important relationship between clinician and patient, which is trust. That needs to be there, and we all have a responsibility to try and maintain that and to support that for the clinician and for the patient. But one of the issues raised also was around the fact that throughout this legislation, this proposed legislation, which is obviously it's a really complex piece of medical legislation, that doctors haven't been consulted or spoken to. So I would just maybe like your feedback, if you have any on that, in terms of the bill being proposed and brought through its different stages, and maybe any correspondence or conversations you have had with the Minister around some of your concerns around that. Thank you.
Yeah, thanks for that. I'm glad that is being sort of actively looked at and championed, the psychological support. And hopefully that'll bear fruit. I think it was, as Carolyn said earlier, it was very disappointing to hear some of the language used. And we do need the trust of our patients, and we would see this as a very backward step. If the bill was passed, we'd be going back into a situation of a very grey area, as Carolyn has said, where we would be trying to make decisions based on maternal mental health and mental well-being, and we already know that, I mean, certainly our trust challenged that because we felt that the mental health bar in the older legislation was set at a very high level, and in fact what was happening wasn't legal, and I think that led to that period of 6 years where doctors didn't know what they were doing, so or what they could do or couldn't do, and that ultimately impacted on us as physicians, but it also impacted on patients, and we really do not want to go back there because it's incredibly unsettling within our units for all our staff. You know, people not happy with what's happening, other people really uncertain what's happening. It's really debilitating, to be honest, and we would be very fearful if that bill was passed that we'd be back into a really difficult situation for us as doctors, but also patients, as you have rightly said. The small numbers would definitely be very affected, and there would then be a ripple effect from that onto their wider families, and also a ripple effect down into other decisions that we currently do make with certainty. You know, that we would, even if you would then be looking at that and going, well, look, is that okay to make that decision or not? And I think, as Carolyn, she said earlier in the conversation, she was very clear about how, you know, how that could affect all of us. So we would be very content. We know where we are with the guidelines at the minute. We really know where we are with everything, and you know, and I think we need to be trusted, and you know, we need to be supported, and you know, and as I've said before, we do have multidisciplinary teams with good governance. We have post-mortem backups. We have regular meetings with our pathology colleagues over in Alderhay, which actually, although it's based in Liverpool, offers a really good service for patients from Northern Ireland, much better service than we had while it was all collapsing over here for years. So we actually have a really good quick turnaround. We get a much quicker turnaround in reports now, but it's not ideal. Obviously, we would love to have the same quality of service based at home, but that's maybe a discussion for another day. But we do have good supportive links with Alderhay. They've been in all of our hospitals discussing things, so we have that backup. So we would urge people not to change things and to continue to support, and don't use the language that has been used, which is inaccurate. So I think that's, maybe Carolyn wants to say something. I think she's maybe already dealt with that earlier in the conversations.
Thanks. Yes, just to my knowledge, there has been no correspondence with any, certainly not with any fetal medicine consultants, and I don't think any of my other colleagues in wider obstetrics and gynaecology were consulted prior to the reading of the bill.
Okay. Listen, Carolyn and John, thank you very much.
Okay, thank you, Leah and panel. And going then, finally, in terms of indications, I have now to Ciara Hunter. Go ahead, Ciara, let on.
Thank you, Chair, and thank you to both John and Carolyn for being here this morning. Your contributions have been very helpful, and it's really helpful for myself to hear kind of the medical insight and aspects of this. I really appreciate the point that you had made around prenatal screening here. I've raised over the past number of weeks to other panels about, compared to other parts of these islands, it's really quite poor. So just to note that point. But today, essentially, I have a question. I'm just looking a bit of clarity around gestation. And at what point of gestation most fetal abnormalities are found, and also severe fetal impairments. So any clarity on that? I do recognise every case is unique, but any information would be very helpful. Thank you.
Well, most will be picked up at the 19-20 week scan. That's when most structural abnormalities would be picked up, or suspicions of a severe underlying chromosomal abnormality. Some will be picked up a little bit sooner. There will be very occasional major fatal fetal abnormality that might be picked up at the booking scan, but most will be at the 19-20 week scan.
Yeah. And some also, I think, come through to us because a number of patients choose to have genetic testing In the private sector, there are tests that you can have done, a maternal blood sample that looks at the chromosomes of the fetal chromosomes in the maternal blood from 10 weeks. So there are patients that come through around the 12 to 14 week stage as well, with a diagnosis of a severe chromosomal condition that we know is fetal or severe impairment. But yes, you're quite right. There isn't a wholesale screening program across all our trusts in the first trimester at an earlier point. So we are relying on, I suppose, the scan would pick up abnormality. The other thing to say about that is not all babies with severe chromosomal conditions have a scan abnormality as well. So often when you see a structural abnormality on top of a chromosomal abnormality, it will be again at the more severe end of the spectrum for that chromosomal abnormality.
Thank you both. That's great. Thank you.
Sorry, Chair, you're muted.
Thank you, Clerk. And thank you, Carolyn and John, for both your written presentation and your contribution and evidence here this morning to committee. That has been very, very useful. And I want to wish you all the very best in your important work, and to thank you for attending and giving us your evidence today. So thank you, panel.
Thank you.
Okay, members. I'm going to go now just to double check with Clerk. Do we have the next? Yes, we do have the next panel, I think, ready to go, members. So I'm going to propose that we move straight into that, given the time pressures this morning. So this is item 6, another evidence session in relation to the Severe Fetal Impairment Abortion Amendment Bill. And this briefing is from the Presbyterian Church in Ireland, Christian Action Research and Education, Both Lives Matter, and the Evangelical Alliance NI. So this is a further evidence session, and I refer members to the written submissions received at tab 6.1 to 6.4 of your pack. Representatives from a number of organisations are here today to give evidence on the bill. And I would like to thank members for continuing to conduct these evidence sessions in a way that is compassionate and considerate of the significant issues that we are dealing with in relation to this bill. So I would now like to welcome Miss Carolyn Jardine, who's Public Affairs Officer with the Presbyterian Church in Ireland. Good morning, Karen. Can you hear me okay?
Good morning, Colin. Yes, I can indeed. Thanks very much, Chair.
Good morning. And we're joined then by two parent representatives, the first of which is Miss Grace Cahoon. Can you hear us okay, Grace?
Yes, I can hear you, yeah.
Thank you. Your volume's a little bit low there, Grace, but hopefully we'll get you okay. We're also joined by Mr. Stephen Lowry. Stephen, can you hear us? Can you hear us okay, Stephen?
Yes, thank you.
Thank you. Okay. Then we are also joined by Miss Sarah Pike, who is the Early Human Life Policy Officer with Cura NI. Can you hear us, Sarah?
Yes, thank you. I can hear you.
Thank you. Miss Dawn McEvoy, who is co-founder of Both Lives Matter. Can you hear us, Dawn? Thank you. And Mr. David Smyth, who's head of Evangelical Alliance here in the North. So listen, I very sincerely want to welcome all of you to our committee meeting here this morning. It is clearly a large panel, and that will provide its own challenges in terms of how we manage the session, but we'll do our best, and we'll try to get that conducted with the technological limitations that we have. So I'm going to go back then to yourself, Karen, and could I ask for some very short initial remarks, if you could advise how those will be done, and then we'll go to questions and answers from members. So we'll go back to you, Karen.
Thank you, Chair, and thank you for the opportunity to speak with the committee this morning. I will speak briefly and then hand over to David Smyth and then to Stephen and Grace. So that'll be the presentation, but hopefully then Sarah and Dawn can be brought in during the question times. And just as we start, I just want to acknowledge the professionalism and the compassion of the previous witnesses that have been before the committee this morning on this very, very complex subject that does, as the chair has said, require compassion from us all. One of the things, I suppose, is that the committee is doing its work this morning. We really appreciate our locally elected representatives taking the time to hear a range of views on local legislation, and we want to thank you for doing this work, which is difficult at times. In relation to the bill before us this morning, I suppose it's recognising that it removes the principle from law that prospective disability is a reason to terminate at any gestational limit, and recognising that law shapes culture. So a lot of the evidence that we've heard this morning already reflects the culture that exists in Northern Ireland today. And I suppose what some of the things that we would like to talk about is how that culture might change, say, over the next 10 or 20 years in terms of what we see what's happening elsewhere in the UK. So perhaps if I hand over to David and he can just make some brief remarks.
Thank you, Karen. Go ahead, David, please.
Thank you, Karen.
Sorry, David, just before you start, sorry, and it's particularly important given the size of the panel we have. If I could ask everyone who's not speaking to please try to ensure that you're on mute during that time. It's also hugely beneficial if people can use headsets. I realise not everyone might have access to one, but if people have headsets, that helps with the sound. So just to make those few remarks. So sorry, David, carry on.
No problem. Thank you so much. Good morning, committee. Just want to acknowledge at the start that nobody stands nowhere, that there's no neutral opinions here. We all come with our beliefs and our values, be they socialist or capitalist or whatever that may be. But I believe that everyone present this morning on these screens is concerned with justice, equality, compassion, freedom. But we might define those quite differently, and we might even be offended by each other's definition of justice or compassion. And so the question for you as a committee, this is definitely a medical question, it's a legal question, but there are questions that medicine and law cannot answer alone, deeper questions of what it means to be a human being. And we represent maybe religious beliefs this morning, but also it's not just beliefs, it's about how we shape those into actions by those whom we represent, into practical actions of care and support and solidarity and walking with people in difficult situations. Just want to make the point that it's entirely legitimate and proportionate to advocate for the protection of both lives in legislation. Under UN Convention and EU law, there's no absolute right to abortion, and admittedly, there's no absolute right to life. And so a wide margin of appreciation is given to member states to decide their laws on this area based on cultural values. That comes from the case Vaud versus France. The laws brought into Northern Ireland in 2019 and the regulations of 2020 were of a maximalist nature, basically transplanting the CEDAW agreement into local legislation. But many more countries take a more minimalist approach. And it is entirely legitimate and proportionate that a legislature with devolved responsibility for abortion could decide to acknowledge and protect both women and unborn children in these circumstances to some degree. In the UK Supreme Court judgment of 2018, Lord Manch said, in principle, a disabled child should be treated as having exactly the same worth in human terms as a non-disabled child. This is also the consistent theme of the United Nations Committee on the Rights of the Persons with Disabilities, expressing concerns about the stigmatizing of persons with disabilities as living a life of less value than others, and about the termination of pregnancy at any stage on the basis of fetal abnormality, and recommending states to amend their laws accordingly. Both law and medical care across the UK and these islands already acknowledge the continuity of care pre and post birth. That's why if a child in the womb suffers medical negligence or malpractice, they have until 3 years after their 21st birthday to bring legal proceedings. The adult is legally recognised as one and the same person as the baby who was in the womb. That brings me to that final point, my final point. I am someone with a cleft lip and palate, and I was interested to listen to the previous discussions, and I note the committee's concern and the clinicians' concern that there is a perception out there that abortions are happening solely on the basis of a cleft lip and palate or club foot. Now, my understanding from the data is that that has happened in the past. In 2003, a legal case was brought specifically about that by Joanna Jepson. And so I would be encouraged if the committee today would state their support for a bill like was brought to the UK Parliament last year, which would specifically stop or prohibit abortion based on those grounds, so that there is no confusion out there. I think it'd be really helpful for the public to know that. At this point, I'm going to hand over to Grace. Thank you so much.
Thank you, David, and thank you, Grace, and go ahead, please.
Thank you for the opportunity to speak today. I'm a mother of two, to James, who is 6, and Harry, who is 18 months and has Down syndrome. It was a shock when we heard that Harry had Down syndrome after a relatively straightforward pregnancy. Harry was in hospital for a period of time following his birth, and during this time we tried to get our heads around this news. How would we share this with friends and family? How would everyone react? How would we tell his brother? Thankfully, immediately after Harry's birth, we were surrounded by positivity and encouragement, and we continue to be. We do worry about the future at times, but what parent doesn't? We have a happy, strong, determined little boy who is adored by his brother, who just sees him as Harry, or in his words, his best brother. Down syndrome does not define who Harry is and what he will become. At 18 months, he's already striving to achieve and amazes us every day with how much he's learning and developing. I'm proud to sit here today representing many of the other amazing children and families we've met on our journey so far, many who would echo the thoughts I'm sharing today. I know from personal experiences I've heard that not all women who have had prenatal or postnatal diagnosis of Down syndrome for their baby have had the positive response from medical professionals that we've thankfully experienced, particularly those in England. I'm concerned that this law will reinforce discrimination against Down syndrome here in Northern Ireland, and that our culture will begin to change. When a parent is told there's a possibility of a diagnosis of a disability such as Down syndrome, they should not lose any rights as a result. This is about equality. We live in a society that constantly talks about equality and inclusivity, yet here we are taking away the rights of a baby like Harry before he or she is even born. My older son would be protected after 24 weeks. My youngest could have been terminated right up to birth. Why? Do we want to live in a country where Down syndrome and other disabilities are seen with such negativity and fear? How would a change in this law impact adults and children with a disability? It would make them feel equal and help them know their lives are valued. Thank you. And I'll now hand over to Stephen.
Thank you, Grace, and thank you, Stephen. Go ahead, please.
Hi, everybody. Good morning. Can you hear me okay? Yeah. You can hear me, yeah?
Yeah, we're hearing you fine, Stephen.
Okay.
Go ahead. Thank you.
Well, yeah, good morning. Let me say thanks as well to the committee for the opportunity to speak. I've been asked just to share some lived experience as a parent of a child with disability. My wife and I, we found ourselves thrust into the world of disability when we became parents to our daughter, Rose. Rose was born with severe mental and physical disabilities. We didn't plan it. We didn't choose it. And I noticed that the term bereavement has been used already this morning. And I guess in hindsight, that's fairly true. We entered into a grieving process, perhaps for the child we didn't have. Perhaps we grieved over the life that we could no longer live. And maybe we grieved the perfect child and the perfect life. And maybe grieve is a fair enough term, because it's painful to learn suddenly a lesson that usually requires time, a lesson that we all will learn, that the perfect life and the perfect child are fallacies, and that in life there are no peaks without valleys. If there was one thing that I want to express this morning to the committee, it would be that what is often seen as a tragedy is not. We think it is because disability cuts across the grain of our hopes for perfection. Disability can be seen as a as an intruder into how we expect our lives should be, or how we want our lives to be. But in being asked to share my experience this morning, my honest experience is as far from a tragedy as can be. My experience is not a tragedy. It's more of a love story. Being a special needs parent has brought me into a world of emotions previously unknown. Grace has just said that all parents have worry, but there is a worry that's unique to special needs, and I would go so far as to say an angst, even, and it would be disingenuous to deny that. But there is also a tremendous joy in my world of special needs, and it would be equally as disingenuous to deny that. Now, that joy is in the same cup as the angst, and it's a cocktail, and I have to drink them both. But this joy that I want to talk about, I encounter this joy. I encounter it in myself. I see it in my wife. I see it in other special needs parents and caregivers. In Rose's school, it's evident, and it's a joy that I think is rooted in the act of caring. It's a joy that comes from the act of kindness, even an exercised offering of kindness over a lifetime. It's a joy, I believe, comes from a focused life of caring for the vulnerable, of giving dignity to the very least. And I have found a profound sense of meaning and life purpose in those things through disability. I can fully understand why a diagnosis of disability is seen as a tragic, and a term used already this morning was the unthinkable. And I can see the difficulty in asking people to accept something they don't want. But my experience is one of a very welcome tragedy, a very welcome disruption to a perfect life. My experience is a sorrowful joy. And my story is not a tragedy, but it's a love story. Thanks for listening.
Yeah, thank you. Thank you, Stephen. And so I'm going to go now then to members' questions. I suppose first of all, myself in terms of a question, and I suppose in terms of clarification as well, I would just like to say that I know I certainly referred to bereavement, and I was talking, when I was saying bereavement, I mean actual bereavement, either post-birth or pre-birth. I'm not for a second suggesting that anyone would see a diagnosis of disability in itself as a cause, and I agree with you, Stephen, on that. I know very, very many people with disabilities, many of whom are, in fact, I work with on the all-party group on disability, are some of the best advocates and activists themselves, and some of the most able people. So by no means, I think it's very often our society that disabled people rather than people themselves in terms of the supports and accessibility and all of those issues. So and I know people and have people within my own family with Circle who with Down syndrome, who are some of the most greatest and fun and able and lovable and thoroughly enjoy life people. So I don't have any issue with that. I suppose one of the key things I would like to explore is in terms of the panel's experience in terms of support and what support has been made available to allow people to continue with pregnancies which are going to present particular issues, or that additional support may be needed. And we have heard in the earlier session about a lack of support at times in terms of psychological support. But are there other areas of support that you would like to flag up or indicate as a potential positive, or that where there have been negative experiences as a result of services not existing? So Karen, can you generally sort of field the questions to whoever you feel most appropriate? Because I think we want to be clear that we get a substantive answer and only additional if it's something additional, because we just don't have time to ground everybody on each answer, unfortunately.
Absolutely, Chair. And I suppose if I make one brief comment and then perhaps hand over to Dawn maybe to kind of reflect on that. From PCI's perspective, Presbyterian Church, we have consistently called for better support and care around perinatal hospice care, and some of the services that were described earlier, even that link between the hospice and the hospital, and the support for psychological support for families, for mothers. We're fully supportive of finding the extra resource and funding for that. And I suppose that would maybe be a question about where is best to invest our time and our resources. But I'll ask Dawn to come in on that.
Thank you, Karen. And if I can just repeat what's already been said, thank you for the opportunity to be here today. It is a privilege. As Both Lives Matter, we campaign broadly on the issue of abortion. Speaking specifically to this bill, our concern actually was to take a back seat, and we wanted to support the disability campaigners who were taking the lead on this campaign. There's obviously a connection to abortion and the discriminatory aspect of abortion, precisely because of disabilities being singled out differently than able-bodied babies have the legislation under law, or have the legislation in law. From our perspective, hearing their voices, as I said, was of primary importance, those living with disabilities and their parents. And if I can just add to what Grace and Stephen have so powerfully shared, we have a number of stories on our website, women who'd received a fetal diagnosis and were similarly concerned. They faced pressures to terminate. I'm very aware of the previous medical contributions, and this is not about judging particular individual medics, and certainly within the context of Northern Ireland we recognise there's wonderful care that is offered, but we have to listen to the stories of women who are reiterating that they felt pressure to terminate when they faced a diagnosis. And I have 3 stories sitting in front of me today that speak exactly into that. The assumption within the medical profession that they should terminate. None of these 3 stories are, one is for Down syndrome, the other 2 are not. In the first case of a Down syndrome diagnosis, there was surgery required post-birth. The parents were asked if they wanted to have surgery. When they said that they did, of course, because he's our little boy, the consultant said, he may be your little boy now, but one day he's going to grow up to be a great big monster. Story 2, which was of a significant neurological condition. These are 2 university professors, and part of their story is them talking about the power dynamic that they faced and the pressure that they faced for 4 months to terminate a baby that they had said they didn't want to terminate. They were told by the medical professionals it's morally unethical to bring a child into the world who is going to have so many needs and won't have anything to contribute. Their little daughter lived for 5 years, but the distress of those conversations continues to live with them, and they feel that it's really important to get that story into the public square. The third story is of a genetic condition, and it was not picked up pre-birth but post-birth. But the consultant that was working with the family when they were talking about future pregnancies said to the family the risk is 1 in 4 for a similar condition. But don't worry, we can test it, and if it has it, we'll get rid of it for you. Now, I'm not suggesting that every medic responds in such a way to a diagnosis of disability, but it does speak into the assumption that can be to terminate, that termination is the moral or the best option. And from the perspective of the families that we've talked to, very often there is no other alternative talked about, or it is simply terminate or go away and deal with it on your own. There is very much a need for more support. There's a need for personalised pathways of care. There's a need for appropriate language to be used, for parent-centred information, not scary medical language. We do know, as has been talked about, that out of the pregnancies that where a fetal diagnosis of Down syndrome, for example, is received, 90% of those parents do choose to terminate in GB. But we know, looking elsewhere around the world where comfort care and good support services are on offer, up to 90% of parents choose not to terminate. So that speaks into the very real need for better support and care pathways. And if we do think, just finally, exclusively about Down syndrome for a minute, within the UK, there is a problem with termination for Down syndrome outweighing the continuing of the pregnancy because of the lack of alternative supports. We know that £16 per person is given in the UK for Down syndrome. Of that figure, £11 out of the 16 is spent on screening, with only £5 spent on research. So the vast majority of the funding goes towards screening. And then we already know, as has been said, the vast majority who find out they have a diagnosis of Down syndrome pre-birth will choose to terminate. Our concern is that that eugenic culture does not come into Northern Ireland. We don't have a culture where disability has ever been possible to discriminate pre-birth. As Lord Shinquin said before the law changed, Northern Ireland at that point in time was the safest place within these islands to be diagnosed with a disability pre-birth. As much as we do and have taken on board what the previous contributors have said, there is a problem with eugenics within medicine within the UK, and that cannot be allowed to come into Northern Ireland.
Thank you, Dawn. So I'm going then to Jonathan Buckley, and then I have Carolyn Killen. So go ahead, Jonathan, please.
Thank you, Chair, and can I thank the panel for their presentations thus far. Some very emotive stories. I too share that approach that David had outlined about that road of justice and compassion in relation to this issue. And I suppose probably what I would like to ask to Dawn and to Sarah to begin with, why do you believe this bill is needed? What difference do you think the bill will make to the families of those living with disabilities in Northern Ireland? And how do you think this bill will help pregnant women? So I'll start with Sarah, if you don't mind.
Hi, thank you so much for inviting us to speak. I'm sorry that my more local colleague to you, Rebecca, was not able to make it. I think I would say, in terms of the need for this bill, I'm really aware, reading through some of the submissions, that practitioners have said they don't recognise the stories coming from women in England about the pressure they felt to terminate. I'm really glad about that. But as Karen has already said, we know that law does shape culture. And we are aware in England and Wales that a number of women face really difficult situations. There's the BBC reported on a woman, Emma Meller, who faced a situation where she was asked at 38 weeks by her doctors. She said they made it really, really clear that if I changed my mind on the morning of the induction, to let them know because it wasn't too late. And we also, there's an excellent report that's been produced by a number of Down syndrome charities that they did some research on the experiences of women in England and Wales. And they said for 69% of women who received a positive diagnostic test result for Down syndrome, they were offered a termination when the result was given. And that speaks to a culture. And regardless of how non-directively that is offered, for some of those women, that's really distressing. That's not the conversations they want to be having on their antenatal journey. So I think for those women, this bill is really important, and we don't want to be in a situation where women in Northern Ireland are facing those same distressing conversations during their pregnancy.
And if I could just then add to that, Jonathan, thank you. A friend of mine who lives with quite severe physical disabilities, we were talking about the bill. And when I first mentioned it, his immediate response was, would that law apply to me? And it's those voices, that's why it matters. It's how it's received by people who are living with disability when they realise, for example, another family I know, they have 3 children, 2 have disabilities, 1 doesn't. And the mummy has also got disability that would be classed as severe. So from her perspective, 2 of her children aren't protected in law in the way that the other one is. So it's in that way that this law matters. It sends a very clear signal that disability discrimination pre-birth is not permitted. And of course, we know that disability discrimination pre-birth is connected to post-birth. It's the fear of what the lived life will look like or what it won't be able to look like. It's, as one of those stories was, that the born child won't have anything to contribute. And it's a really dangerous path to go down when we measure someone's worth in how they're able to contribute. How do we measure that? Is it a financial contribution? We know that, for example, again with Down syndrome, I have 3 able-bodied daughters. I would wish that they reported similar feelings of happiness and joy and satisfaction with their lives and how they look, as to how we know that Down syndrome people respond when they're asked. 99% of people with Down syndrome indicate that they're happy, 97% like who they are, 96% like how they look. How do we determine whether life is worth living? How do we determine suffering? How do we determine pain? And unfortunately, legislation that permits abortion for disability sends a signal that those lives being lived aren't worthy in the same way that able-bodied lives, and that's why this law matters.
Okay, thank you. And I think many of you would agree, I'm not going to put words in your mouth, but from what I've heard from the presentations, that your overwhelming thought is that the culture that exists among medical professions is that for most is pushing down the avenue of termination as the only option. Can I ask, in that regard, obviously we have had presentations from paediatricians and just before you actually the Royal College of Obstetricians and Gynaecologists who would say that is not the culture at all, that there is a choice that is offered to women, but that doesn't, and in even relation right up to birth, I think it was Sarah, you had mentioned about the particular case right up to induction. What's your response to the medical professions that tell us that this just does not happen?
Jonathan, again, if I can just start, I suppose there's a culture in Northern Ireland that has been shaped by the laws and how our culture has dealt with these circumstances up until this point. But what the Fetal report and the legislation that came in 2020 does is just change that culture completely. And we're maybe not talking about what might happen tomorrow or next week or next month, but we're talking about 10, 20 years down the line, and about establishing a set of norms where abortion is seen as maybe the first port of call rather than the last resort. And I think how the medics were talking this morning was about the case of last resort, but maybe I'll bring Grace in to reflect on that, and maybe Sarah might have some comments as well.
Yes, go ahead, Grace.
All right. I think just with our kind of entrance into the world of Down syndrome in the last year and a half has probably opened my eyes to this more. Women through various kind of support groups that I would be in, sharing their experience of being asked repeatedly at appointments when they've been told termination is not something they're considering, being put under pressure. A personal friend who was put under so much pressure she didn't have any more scans with her first child and didn't have any scans with her second and third child. So that's the reality for women, particularly in England, where abortion has been available. And I guess my fear as a parent with a child with Down syndrome is that this would become our culture in Northern Ireland. It's maybe not happening as much here, but I am aware of girls who have not had positive responses when they've had a diagnosis of Down syndrome. Information that's been given has been outdated. One family I know who have a child with a disability were told that she would never walk, never talk. This is when mummy was pregnant, when emotions are already running high. She would never walk, she would never talk, and she would never call her mummy, which is a horrendous thing to say to somebody during pregnancy. But that little girl has gone on to walk and talk and do amazing things. So While in Northern Ireland, it might not be happening just as much as it is in England or in Scotland. As our situation changes, and as Karen says, looking forward into 10 or 20 years down the road, it would be a terrible thing. Lord Shinkwin, as we've talked about, said that Northern Ireland was one of the safest places for an unborn baby, and we would hate it to turn into somewhere that isn't safe. But it is happening here, and it will probably happen more, I feel, if this bill isn't put in place. It would be a sad situation for children coming into the world with disabilities to be seen differently, and those parents to be maybe anxieties to be placed in their minds during pregnancy that weren't previously there by medical professionals. So my concern as a parent is that, as Karen says, the culture would start to change as time moves on.
Can I just respond?
Thank you, Grace. And Sarah?
Sorry.
Briefly, Jonathan, please.
Yeah, from Grace, from your perspective, what would you say then to those that would say that it's okay on one side advocating for a pro-life position, but in relation to disabilities, that the support services after that birth are simply not there? What's your view on that?
Yeah, well, I mean, from my perspective, I suppose we entered into this world during COVID, so it was different maybe experience. But I mean, we definitely have a team of professionals who are very involved with Harry and very supportive of his development and support for us. There's a lot more happening out there, I feel, now than maybe there has been in years gone by, specifically in relation to Down syndrome. There's a lot of support groups available there, very active support groups here in Belfast. And support is there. Yes, probably there could be more, but I think if we go down this road and take this journey into encouraging people in a positive way, to not consider abortion and to continue with pregnancies, and the support will be there, then as an executive and as a country and as people like ourselves who are parents, we need to look at that and maybe look at the ways we can support families more. But there definitely are supports there. But it's definitely something I think as a country moving forward, we could be probably putting more into and given more time and more attention and immediate care after hospital and during that diagnosis period. I mean, we had excellent care, I have to say, for our child. We had unbelievable care in the hospital, psychologically supportive for our family and practically then afterwards for Harry. But it's definitely something that needs looked at and definitely more could be going into it here, yeah.
Thank you, Grace. And Sarah, were you looking to come in on Jonathan's previous point?
Yeah, I mean, in terms of the comment about saying that this just doesn't happen, I think, again, I would point back to the research. We know that studies have been done that found that of women who received a high chance screening result for Down syndrome, 50% were offered terminations despite having already said that they don't want one. And I don't want this to be an attack on clinicians. It's really not. I think clinicians are in a really difficult position because if their role is to support women to make informed choices, and one of the choices that is legal in these cases is termination right up to term, then in a sense it's their role to let women know that that is an option. But yet that is really distressing for many of these women who don't want to be thinking about termination during their pregnancies, particularly not in late stages. They do find that really upsetting. And I'd also point to, so I think you have Don't Screen Us Out, a representative from Don't Screen Us Out coming later. Do you know they have an open letter that's been signed by more than 1,500 people with Down syndrome and their family who are expressing concerns about the law as it currently stands and who are speaking in support of this bill. So there's a significant number of people who are really concerned about the impact of this bill. And we also know that, some of you might be aware, there was a storyline in Emmerdale about parents choosing to terminate a pregnancy where there was a high chance screening result for Down syndrome. And actually that kind of storyline it's really upsetting for children and adults with Down syndrome and their family. But because that is legal, in a sense, that's a legitimate storyline, but it is really upsetting. So I think those are the kinds of things that this bill will be really important to stop happening.
Okay. Thank you.
Thank you, Sarah. Okay, thank you. Thank you, Jonathan.
No, just I don't know if there is any members indicating. I would ask,
so
but if you coming at the end,
there is. I have an indication from Carolyn and Carolyn. So go ahead, Carol, please.
For your testimony and indeed your written testimony to the committee as well. Some of you have alluded to listening to the previous contributors from the Royal College. And indeed, some have acknowledged the fact that a lot of the experiences of women who felt almost coerced into making a decision or considering a decision about termination was more prevalent in England and Wales, but Global Women felt that that was the case for some of them here. My concern in that is that even just listening to the two clinicians this morning, it's quite obvious to me that they are trying to give as much support to women regardless what decision they're making. And I just want your views on that. And then the other aspect is that in relation to, if the bill doesn't go through, what do you feel the difference would make to the campaign that you have? So thank you.
Thank you, Carol. Again, if I start, thank you for your question, taking time to listen to us today. I think one of the comments that was made by your previous contributors was that many women and their families, when they're well informed, that they choose to continue on with a pregnancy that either may result in a baby maybe not living for very long once it's born, and I think maybe some of the focus was maybe around some of those very difficult cases rather than some of the other cases that maybe we are talking about today. But I think it's the cultural shift and the potential for change over the next 10, 20, 30 years that we are concerned about. But maybe if I bring in David to speak into this.
Thank you.
Yeah, go ahead, David.
Great. I think one of the concerns we would have is that what many of us would see as literal dehumanization doesn't do anything to address the structural inequalities and injustices that young people growing up in the world with disabilities will face. It doesn't alleviate poverty. It doesn't tackle the core roots of many of the problems. I think Carol's question was very helpful about the campaign. Regardless of this legislation passes, we do want to see much better support services for women and their families, for people growing up with disabilities. And I think it's maybe just important as well to name that there are, as we said, different worldviews. There are different end goals sometimes as well. So sometimes there's the accusation that people only care about this because actually they care about abortion and ending abortion. It's no secret that we would like to see further changes to the law. We don't think it strikes the right balance in protecting both lives as far as it could. But the churches that we represent and many others, and Grace and Stephen's testimony today show that it's not just a belief that we abstractly threw out there. We are working on the ground to support families with disabilities. Now, there's a long way to go with that, but we want to, this is not a ruse, we want to be upfront about both aims. I think it's also important that maybe some of those who are campaigning against this bill are clear that they want to see abortion in any and every circumstance up to term. Because I think it was, again, helpful to point out that abortions for cleft lip and palate, for instance, would not be supported. But clarity around some of that, I think, is helpful rather than the sloganeering that we sometimes fall into. But just to reiterate that point, I think we do have concerns about long-term culture change, and that offering abortion for disability doesn't actually address many of the concerns of the structural and systemic issues that those living with disability are facing. Respite care, to name one at the minute, special educational needs education, the list could go on and on.
Chair, could I maybe bring in Stephen just to speak for a couple of minutes? Stephen also has a role within PCI about the services that we provide for people with disabilities. Maybe Stephen could speak for just a couple of minutes briefly about that.
Yeah, thanks, Karen. I have a role within PCI. I'm the convener of disability services. Found it quite interesting. I was in a meeting. We have a council for social witness, and I was given a report on my role there. And it just struck me that as we were getting our thoughts together about arguing for the dignity of life and the dignity of people with disabilities, that it's not just talk. It's not just something that we say as theory or principle, but the Presbyterian Church owns and runs 4 residential care homes for adults with learning difficulties, which can either be full-time residency or respite services, and that's fully funded and fully staffed by PCI. So this is something we take seriously, and it's something that we it's something that matters to us to that extent.
Sorry, Chair, you're muted.
Okay, thank you. Thank you, Clerk. So, Jonathan, you had indicated, I think, at the end there that you would have liked to come back in for another question if time allows. So I don't see any other indications at this point. So go ahead, Jonathan, with another question. And this is the final question, please. Thank you.
Yes, no, look, I suppose, Chair, it's been a very helpful session. And I just wanted to maybe get a different perspective on this. And I think, is Dawn still with us? No, she's not.
Clerk,
no,
can you advise if Dawn is still on the call?
Yes, she was there and then just went off the call. We'll try and get her back on as soon as possible.
That's okay. It was specific in relation to the Both Left Matters and their campaigning towards this, but no, that's if she's not, that's fine, Chair. Thank you.
Okay, thank you. Well, listen, I want to thank each and every member of the panel for taking time this morning to come to the committee, to contributing your evidence, both in terms of written evidence and your evidence here this morning, and to wish you all the very, very best in the time ahead, and that the supports that are so badly needed for everyone, and some of the people on the call are in that same position themselves. And I think there is certainly something that we all should be looking at in the longer term in terms of how we can provide better support. I think that's clear, and that has emerged very clearly across these discussions. So thank you, panel, and all the very best. Good luck for the time ahead.
Thank you.
Thank you.
Yep, thank you. Okay. Thank you. Okay, members, I am going to propose then that I'll just allow the members of the panel to leave there. Okay, members, I think what we should do, given the time constraints, what we should do is go to correspondence. We'll deal with correspondence, and then we will just I'll check with Clerk then. Clerk, should we break at that point then for the plenary session? Or would we have time to take the SRs, or how are the officials in terms of timing for the SR section?
Chair, we've let the next group of witnesses that don't screen us out in Down syndrome know that it'll be after the plenary. We've also put an initial note out to officials on the SRs that it would be after plenary as well. So I think we're probably best covering correspondence and the rest of the items, and then come back after for the evidence sessions.
Okay, so members, then I propose that we will move to correspondence in light of that, what the clerk has briefed us there. Are members content that we do so? Yeah, thank you. So members, I would like to draw your attention to a number of items of correspondence. Item 10.3 is a written briefing from the Department on the targeted response to the identification of the Delta variant in the Kilkeel area. So I know that the department did provide a written briefing outlining the activity and the actions that were taken in Kilkeel. I have since welcomed that, and I think that is an appropriate response to, and it's good to see the contact tracing and the testing available to move into an area and to seek to isolate the spread of the virus in that local area. However, there was no information in relation to what the department are doing in relation to the Delta variant more generally, how they're planning to ensure that the increased transmissibility and the reported increased hospitalisation are going to be dealt with. And I'm acutely conscious that our hospitals continue as we speak to operate at over 100% on a daily basis. So there is really no capacity or room within the system for any increase in that respect. And I'm conscious of the impact that disruption to hospital services has caused to the waiting lists. So would members be content? Well, I'll take comments from members and then see where I think we should write and ask the department to provide a further briefing in terms of what this means, in terms of their response, and in terms of the advice that they're providing to the executive in dealing with COVID generally and the dangerous variant of concern, which is Delta particularly. So any other comments, members? Would members be content that we write to the department seeking further information on the planning that's now in place? Yep, members are content. Thank you. Item 10.5 is a response from the RQIA to the committee's request for progress on the urology work programme. Do members have any comments in relation to that item of correspondence?
Yeah, Chair,
Carol, yeah, go ahead.
Yeah, I mean, we've consistently raised this. I just think it's concerning. We are still waiting on the details of when the neurology inquiry will start. But in relation to this, I think we need further clarification, if not the RQIA to come back to the committee.
Okay. Would members be content with that proposal? Yeah, thank you. Item 10.11 there is from the Stroke Association seeking support for a motion in the Assembly on progress on stroke services. Could maybe suggest that members would look at that individually in terms of that correspondence. Do members have any comments in relation to it or content to note?
Note.
Yeah, members content to note. Thank you. Yeah. Item 10.12 is a response from the Chief Executives of the Health and Social Care Trust to the committee's invitation to give evidence on the severe fetal impairment abortion amendment bill. So I'll take comment from members, but I have to say there has a number of issues have arisen throughout the course of our consideration on this already, including the provision of screening, additional support, which has come up strongly this morning, counselling for mothers and families and psychological support, safe zones. And I do believe it would be good to hear from the department and the trust on these issues. There are clearly will be significant implications for trusts in relation to the bill we're discussing. So I think we do need to hear from trust, but I wonder what members' thoughts are on that.
Sure. Yeah, I agree.
Yes, Carol, go ahead.
I agree, just given the issues that we've heard this morning, but even those we heard last week and previous from witnesses also. I think the way in which personally, I felt the way in which the trusts responded was a bit dismissive. But I mean, you can get over that. I just think they have a substantive role in relation to this, and I think we would all look forward to hearing from them.
Thank you, Carol. Paula?
No, just very much concur with what Carol just said there. I think we have to hear from all sides in this in our deliberations. Thank you.
Thank you. So members are content then that the clerk liaises with the department on trust to schedule that briefing. Yep. Thank you, members. Have members any comments or proposals on any of the other items of correspondence in the main pack there this morning, members? And if not, are members therefore content with the actions proposed on the main correspondence memo? Yep. Thank you. The table pack then contains a number of further items, members, which I'd like to draw to your attention. At tab 10.17, there is a letter from the Minister advising that the British Government is laying a new SI in Westminster regarding the implementation of the EU medical device regulations. That SI will enable the North to continue to align with current policy here and in Britain. That is something I think we are scheduled to have a briefing from Brexit, on Brexit from Cathy Harrison and her team. So I wonder, would members be content to note for now and we can raise that SI, because clearly medical devices are an issue that are of concern, and I think it would be useful to hear more from those people working on that before we make any consideration on that. Would members be content with that, or any other comments? Yeah, thank you, members. Tab 10.18 then is a paper from the department in relation to the cross-border reimbursement scheme. The paper outlines the eligibility criteria and the process. Do members have any comments, or again, would members? I'm conscious that we will have, I think, Patricia Quinn Duffy in the Brexit briefing. There may be an opportunity maybe to add on an additional briefing to get some further information in relation to this item. Paula.
Thank you, Chair. We were all in the chamber on Tuesday when the Health Minister gave his the overview of the framework, and I asked him specifically why a similar scheme was not being replicated for access for people in Northern Ireland. I don't see that there was an EU imperative that's those arrangements for cross-border healthcare access were in place. We're no longer in the EU, unfortunately. I'm just wondering, I didn't think that the Health Minister's explanation for why it's not replicated here to try and ease the pressures didn't think was satisfactory. So I would like to find out why they're not looking at it as an option here in Northern Ireland. If the Health Committee are not wanting to take that forward, I'm happy to put that to the Minister directly. Just as I said, wasn't satisfied with his response in the chamber this week.
Yeah, and the other element of that, I think the eligibility criteria is important, because the upfront costs could be prohibitive for some people, and we need to be very aware that we don't create further inequalities. It's also very, very relevant that this scheme had applied throughout all of Europe, and I do know, and I have assisted constituents to travel to Lithuania and Latvia and other countries. So that element of the scheme, that wider element, has not been replaced. I think it would be useful to hear something on progress on that, and the Minister, I think, has indicated. So would members be content then, in light of all of that we schedule a short briefing on that matter as well? Yeah, members content, thank you. And do members have any other comments in relation to the tabled papers? No, thank you. So moving on then, members, to the forward work programme. I refer you to the tab 11.1 of your pack. At next week's meeting, members, we will be starting deliberations on the Health and Social Care Bill, and that session will be a closed session, and it'll give us the opportunity to discuss the clauses and any possible amendments. So I'm just flagging that to members, really, that next week we will be moving into the consideration stage and that opportunity to discuss those issues. But otherwise, are members content to note the forward work programme? Okay, thank you. Members are content to note. And any other business, members? No. So, members, we will suspend the meeting there, and we will return then at 1 o'clock or 10 minutes after the end of the plenary, whichever one of those two comes sooner, just in case the plenary runs slightly beyond. If the plenary runs beyond 1, 10 minutes immediately following the end of the plenary, we'll resume in session. But hopefully we will be able to resume at 1 o'clock as planned, and we'll pick up on the third briefing at that point. So thank you, members, and I'll see you again at 1 o'clock. Thank you.
Sorry, just to say, Chair, members can just join with the same link. So the same meeting link will allow members to join the meeting again. So it was just to make that clear as well.
Okay, thank you, Clerk. And maybe just send that around as an email for those members who may have dropped off just before you get a chance to give that message.
No problem.
Okay, thank you. So the meeting is now suspended, and Clerk, could you confirm that we are now off broadcasting, please?
Yes, Chair, if you just leave the meeting, that will take us offline.
Thank you. Thank you, Clerk.